Thank you so much for joining us in this conversation today. So today, what I am going to do is share with you the process that we developed as part of an NIH grant that was focused on reducing the duration of untreated psychosis through screening with the PQB and rapid referral to care. We have put together sort of a suite of information that you can use in and kind of modify for your local need. But I'm basically just going to take you through how I would do this, okay? And how I would introduce this in a community setting and encourage people to use it. And then how we would then get referrals to our clinic. So this isn't like a presentation about these things. This is more of an interactive sort of show and tell of the work that we've done and the forms that we have used historically. And one of the pieces that we would be providing some support with through the TTA is, with the site folks that you have that work with your site, some practice around how to do these things. We do not expect you to be able to take what I am doing today and turn around and do it yourself tomorrow. What I would encourage you to do is to get the resources, take a look at them, and then practice doing them at your own site with some of your colleagues. How would you, and it could be people that you know and are maybe in this training who are seeing the same thing. Okay, how could we do this? How might we present this? Where might we start? And then as you guys sort of feel like you have a good sense of it, pick some people at your organization or at a partner organization and say, hey, we're going to practice doing this with you. Can you give us some feedback on it? Because we're learning how to do this. Okay, so again, this is not plug and play. I want to be super, super clear because it requires you to have knowledge and experience with early psychosis, which I have many of, much of, a lot of. And this might be newer to you. And so I just want you guys to own your newness and not feel like you have to completely make things up. But there is going to be a bit of fake it till you make it here, where you guys are going to do the best you can. And take the questions you can. And if you don't know the answer, say, that's a really interesting question. Let me take that back to my team and let me get back to you with that answer. Okay, that being said, I am going to share my screen. There's going to be a number of different things that I'm going to show you. So the screen, I'm sharing, you'll notice I do not have my slides in presentation view. There's a reason for that. So these are the outreach slides, the template that we have put together for you. Again, these are available for download. So you can see it doesn't have a program name, right? And some of you may be more familiar with using PowerPoint than others. So one of the things I wanted to point out by having this not in presenter view is that there's this lovely place for notes. So sometimes when I'm first starting to do a presentation, I'll put some notes down here that will help me sort of stay on point or remember the things that I want to say. So here you'll have your program name, the things that you might want to say, or the people who are doing the presentation. The next slide, handouts you should have. So I'm going to go through these handouts, because these are the things that I pass out to people when I do this sort of what I call an outreach and education session. So first is a PDF of my slides. They will always ask you for a PDF of your slides. So it's best to just have them ready. Then we have the overview of psychosis symptoms. So this is a Word handout. It's opening for you right now, that is, again, in the materials that you can access. So you can see overview of psychosis symptoms. Now, for those of you who attended the SIPS and SKID training or have watched those videos, right, you are going to recognize a lot of this language. Perceptual abnormalities, hallucinations, psychotic level hallucinations, as well as subthresholds. So some examples. unusual thoughts, examples. And many of these are pulled from the language of the SIPs in the skin. So I give this to clinicians. I talk about disorganized communication, the line between attenuated and psychotic, these ideas of frequency, distress, level of conviction, and effect on behavior. And you guys can fix this, like this is just a footer. You can change that for your own clinic. Other important developmental issues, how to ask about these. Remember to request a phone interview if any of these symptoms occur. So this is a handout I give the clinicians, okay? And it all relates to information I share in my slides. Then I give them copies of the PQB, the actual screener. I'll show it to you in, this is English. This is the validated version, right? Where they go through and they sort of read these experiences. Has this happened? Yes or no? If yes, how much does it frighten, concern you, or cause you problems? So again, getting at that distress and impact on functioning. So I'll give this in English and Spanish. Please remember, we have this in multiple languages. If you need it in other languages, please just ask. We'll work to kind of get those more available for you. Then I give them the scoring sheet. Here's the scoring sheet. So they go through, circle 0 for no. And if they circle yes, they circle the score for the different, levels of distress. They sum this, and that gives you your total, okay? Then here's the instructions. At the bottom, it says, if this total score is 20 or more, please call us for a brief phone screen. And it puts our number at the bottom. Okay, so I give that to them. Okay, then, and I really try to say for them, these are things for you as staff and practitioners. Let's not, pass these out in a broad community setting. I go to the common questions and answers. Oh, that's not on here. Okay. So one of the things we have learned is that when folks pass this screener out, you get a bunch of questions. And so this was happening in our study. And so we basically worked with other community providers and stakeholders to say, what are the questions you're getting? And then we worked to give them some answers. So that's what this document is. So if you're concerned that the client is actively ill, what to do, or they're having an urgent mental health crisis, this is what you should do. Somebody asks you, is this for schizophrenia? No. So we'll rework this because it still has tablet language, and we'll just replace it with screening and really just try to make sure that you can use these questions and give these answers to the folks who will be doing the screening. Then we have additional ideas and readings. So this is something that can be client and family facing. This form was developed, so advice for caregivers from someone with the illness. So our peer partner helped us develop this. This was stuff that he wished his family had known when he was struggling. Then down here, advice for caregivers from other family members. So this was developed by our family partner about the things that she wished she had known. Okay, so that is here. You can give this to family members or to peers. Lots of good books to read back here on the back. And then additionally, suggested reading for providers. So these are links to a whole bunch of different handouts and resources that we have put together over time that you are welcome to look at. Many of them are from SAMHSA. So additional ideas and resources. Then we have our phone evaluation request form. Okay, so this is how we take referrals in our clinic. It's a fax form. So, but the one thing about faxes is they're HIPAA compliant, right? You send it to a phone number and it goes where it's gonna go. So you are welcome to use this as a document if you, and do email, if you have secure email, whatever you want, you are welcome to do. But let me take you through why. So one of the things we realized is that once referrals started coming in, it was kind of hard to keep track of them all. So you want to have a process set up by which you are regularly tracking referrals. So I felt at the beginning, like my staff was just like, it is kind of nice, and mind you, this was pre-COVID, to print these out, have them in a stack in the office that they could go through, right? And they could triage them with other chart paperwork as the person was moving through the process. Now with COVID, we have moved to more of an electronic system. So what we are now doing is uploading this into the client chart in their electronic medical record. But regardless, we have sort of a documentation tracking process. You could do it in Excel, you can do it in various ways, but you don't want to lose these referrals. Otherwise, you will get angry phone calls from referral sources or parents, generally. So you want to, these are like gold. So here we've sort of built this with important information. Up here, where are they coming from? Who is requesting this? How do we reach them? How long has this person been in your services? One important theme that you will begin to see as you begin doing these services, if you are new to doing this work, is that you are going to start screening and doing outreach in your community. And you're going to start seeing a lot of folks refer people already on their caseload. So clients who have been with them for a while. And, I think that's because oftentimes these folks are out in services in the community. And a lot of practitioners have really been working hard to try to support these clients as best they can. And you're going to come along and they're going to be like, yay, somebody who does psychosis, here you go. And for each of you in your programs, you'll have determined the criteria by which you will be accepting people. And oftentimes we only accept people with 2 years of illness, 3 years of illness, right? We're an early psychosis program. So this date first seen for services is going to give you a sense of how long this person may have been ill already. Okay, you are going to ask the referral source to ballpark. Do they think they're going to be at risk, clinical high risk? Do they think they might have already had psychosis? And so here again, you're going to want to update in past. So my clinic, it's in the past 2 years. For some clinics, it might be the past 3 years, right? This is based upon your eligibility criteria. Right here is where you want them to put that paper PQB score. If you can get them to sign an ROI and put the PQB with it, even better, right? They'll send this whole fax packet back to you. Then you are going to get some very important demographic factors. Now, remember, we are an OAC funded project. OAC loves demographics. So this is your first opportunity to start collecting that data and say, we received X number of referrals. Here are their demographics, right? And from that, the number of people we brought in for eligibility. Okay. Then this next section, please check all criteria that apply. So for us, we have found that a subset of these things have been really helpful, okay? Does this person have active substance dependence? Do they have intellectual disability? Are they currently homeless? Like, this just gives us a snapshot of some other complicating factors that could be coming in with this case. For us, Kaiser insurance is one that we don't serve. So like if you are going out to other providers that do serve Kaiser or commercial insurance and you don't, you might want to update this field. Are they a ward of the court? For us in Sacramento County, that means we are looking at KDA and KDA level services, right? That's something we need to note early. So we would mark that. This item makes them think, has this person been ill for more than 2 years, right? Sometimes they know, sometimes they don't. Next, additional current mental health treatment provider. This for us, we were using this in schools and in other places. And so this was our space for them to indicate from the school, yes, they're linked to this other provider so that we could start collaboration. And then recent ER visit or hospitalization. And then it was like, okay, this person's in crisis. That helps us again, sort of be ready to mobilize. Number 4 is sanity check. Did you actually talk to this person about sending this fax to us? If they have not, do not send this. Do not send any PHI. Stop, right? If the answer is yes, you have told them, great. Here's the information. We will follow up. Okay, so this is our way. We also sort of noticed that like providers, community members wanted an asynchronous way to make referrals. They, it was 5 o'clock on a Friday. They wanted to get this off. They knew we weren't going to respond tomorrow morning, right? So we had everything we needed. Monday morning, 8 a.m., we were ready to follow up. So this is our fax form. And you can work with your TTA kind of support staff to help you make changes here based upon your specific criteria or needs. So these are all of the handouts. Two other pieces that I want to note that we are including in these documents for you, okay? And again, these are things that, because I found this useful. So this is a mailing list. So in the olden days, when we saw people with, faces in a room around a table or something, I would pass this mailing list around and capture where people were coming from. Certainly you could have folks sign in the Zoom or do something along those lines, because we then would create a mailing list where we could have a newsletter and share information out into our community. And so one of the things that we had been doing is having this mailing list. Additionally, I would collect information. I would get a participant evaluation, and that evaluation would cover, their prior knowledge of psychosis, what they learned, different kind of other feedback, like, are we highly trained? I would encourage someone to be referred to this program. Feedback for the presenter and on the presentation, and then down here, demographics. So again, this is another opportunity for you to reflect your work by being able to say, we did X number of outreaches with X number of people, and these were the demographics of the people that we reached. And that can be really helpful in thinking about how you are targeting your outreach opportunities. Like, are you getting a whole bunch of folks who are all like community mental health practitioners? Wow, you're missing like students, you're missing law enforcement. Maybe we need to target another group. All of these pieces are really about trying to make sure you're talking to people who are representative of your community, linguistically, education-wise, professionally, demographically, and then, just making sure you're touching all of the different places where youth may present with psychosis the first time. Okay, all the papers, lots of things to share. And I usually say to people, like, make a little folder, put it in your desk so you have these things. So make a little folder on your computer so that you have these things available. So now these are the slides I start to go through. And I've kind of sort of crafted these things over, I don't know, a decade. So one of the pieces I start out with is just language, making sure everybody knows who we are talking about, right? So I talk about two different kinds of symptoms. I talk about how positive symptoms aren't positive because they're good. I define what these are. I talk about negative symptoms and what these are. And then I talk about how we see this ramping up of symptoms prior to acute psychosis. One thing you will see, you don't see first break on here. Really want to encourage everyone not to use that language. We talk about first episode, acute psychosis. People aren't broken. And we don't want to perpetuate that idea. So people ramp up in these symptoms to the point of acute psychosis. And at this point, they may present, people have this assumption that they end up in the hospital. They don't. Many, many, many people don't. Many families work very, very hard to keep people at home, and so maybe they've presented to the hospital, maybe they've been picked up by police, but more often than not, they're going to come to you through other things. They're going to be already involved in mental health care. This is going to get picked up by the school, or the family is going to bring this to you. So then what we see is the natural waxing and waning of symptoms until somebody gets an accurate diagnosis and treatment. And so again, really normalizing that during this period, they may have been in community mental health or with other healthcare providers, that nobody picked up that this was psychosis. So they may have a whole litany of other diagnoses and treatment until they've gotten to you. And so this period is called the duration of untreated psychosis. And we are working as a state to reduce this, okay? So what we're going to talk about is individuals who have early psychosis, so they have full threshold symptoms within the last 5 years. And then we're also going to tell them about at-risk or clinical high risk, folks who have the onset or worsening of attenuated symptoms. Okay. So we're going to now focus on DUP and tell them why they should be paying attention to these folks, why they need to be alert. And it's because we know in the United States, a very large study tells us that DUP is one of the strongest predictors of outcome, and that should not be surprising. The longer we let any illness go, untreated, undetected, is bad for folks. And here in the United States, data has shown us that, the median DUP is about 1.5 years. When we look abroad to the UK or Australia, the international standard is less than 3 months. So we got a long way to go in the United States. And part of our work in doing this outreach is pulling in community partners to help us be on the lookout, to catch these folks and get them referred quickly to our services. So why do we care so much about this early period, 5 years after onset? The research tells us that this is a critical period where treatment can have its biggest impact. And many folks are still functioning okay. And that can be hard for folks to understand. Like, wait, you mean they can be hearing voices and still in school? Yes. They will be sometimes by the skin of their teeth, hanging in there, but they still have friends, still have connections to family, community, maybe working or in school. And so if we can get in there quickly and support them, we're able to maintain this functioning. It's so much better than having them struggle, lose all of these important things. And then we come in later and try to help them put the pieces back together. We really want to catch them early. We're going to talk a little bit about course of illness and prognosis. We're going to say that early functioning tends to be the best predictor of later functioning. So sometimes folks will kind of wonder, what's the outcome here? And we're going to talk to them about how we're going to look at where they were before they experienced the onset of psychosis. Were they in school? Did they have friendships? Were they, doing well in their daily lives? Or were they already kind of struggling? And that we're going to use that information as part of our treatment plan to help us understand the outcomes that we're aiming for. We're going to tell them a little bit about what we see with the current level of care. Without good care, the care we are offering, we see a life expectancy 10 to 20 years below average, with an increased risk for premature death. This is because of medical comorbidity, substance use. Additionally, death by suicide, which is most common during early illness. We're going to talk about unemployment. And because unemployment is so high, our folks have a high risk for homelessness, poverty, and poor quality of life. Then we're going to talk about economic burden. Almost $45,000 annually for individuals with schizophrenia in our current system of care. And the fact that we know we can do better. So our goal is recovery. We're not just trying to control symptoms. This isn't just about medication. This is really about focusing on the individual, what they want in terms of wellness, independence, citizenship, and that this recovery is we need families. We need natural supports. They are critical to the work we do. And we know that recovery is associated with the engagement of family and support persons in treatment. Okay, so what I've just done is I've sort of teed them up, right? Here's this new thing. Oh, and you've heard of psychosis, but do you understand why we aren't doing as well as we could? And the way things are going right now, outcomes are pretty terrible, and we want to do better by these folks in our community. So then the next part, I say, okay, now let's start talking about the specific signs of psychosis. I want you guys to sort of understand this dimensional perspective of psychosis. And I talk about, we have these changes in thoughts, behaviors, and emotions. So perceptual abnormalities and hallucinations, unusual beliefs, disorganized speech, peculiar behavior. And I'll note here that sometimes it's the unusual behaviors that come to the attention of loved ones or school people, and then they're like, why are you doing these unusual things? Okay. I also talk about the typical age range. We're looking young adolescence to early adulthood. This is when we see this. And we do see people develop it at younger ages. This is why we go younger. We see it at older ages, often in the context of mood disorders or postpartum for women. This is why our age might go up a little higher. We're trying to catch the breadth of people who experience psychosis. Then I talk about the psychosis continuum. I talk about within cultural norms, these unusual experiences we all have that are one-offs, don't really affect us, not upsetting, don't affect our functioning. Then I, pick a couple of examples of those things. And if you guys remember from my earlier training, that was feeling or hearing your cell phone going off when it wasn't actually going off. And then thinking you see a shadow out of the corner of your eye when you're out late at night and sort of hightailing it to your car, right? These are experiences many of us have within cultural norms. But our eyes, our minds, our bodies are playing tricks on us. Maybe we're tired, maybe we're stressed, and we brush it off. But when those things start happening with more frequency or have greater distress, that's when we start to pay attention to them in this attenuated range. So I'm going to link this back in our minds to the PQB. Remember on that, it asks about sort of it's happening, it's bothering you, and it's affecting your functioning. So that is where we're tying it to frequency, distress, and functioning. So then I talk about how maybe those things happen more. And then at the point of fully psychotic, we now are convinced that it's real, it's distressing, and it's impairing our functioning and affecting our behavior. Now, if you remember, the next slide was my personal example of ghosts, which to me growing up in the South was a culturally relevant example. Now, it's on these slides. Y'all are welcome to use it. You can say, I had a colleague who blah, 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 talked about this experience she had as a child. Fine. If you have a better example from your lived experience, it will have a much bigger impact on your audience because it normalizes it, right? So to think about that, if you or your team, like my team uses my example and they say our director, that's fine because it's still someone that's real, right? So I really want to encourage you to think about this and talk with, again, your EPTTA staff as you think about how you could use this to share how that experience would go up this continuum, okay? So this is the part of destigmatization. We're talking about it within cultural norms. Okay. And then we come to the important issues to consider. I talked about developmental norms and how thinking about this with young kids can be difficult, or individuals with autism spectrum or intellectual disability may be more concrete. So these are some of the things we take into account. We also really consider cultural and familial context. What is the larger context in which this person is experiencing this? And this is, again, where I stress how having family and loved ones in the assessment process and the treatment process is so important. And then we talk about environmental factors and trauma exposure. We see very high rates of, self-report of paranoia in the population. And when we start to look at relationships between that and individuals who live in, high stress, high crime neighborhoods or have trauma experiences, it kind of explains some of that. So we are always very mindful for the things that really could be happening that cause folks to have these experiences versus what might not be happening in reality. And so really on this slide, what you are stressing is your group does amazing assessments that take into account a variety of factors, and that they welcome input from all different points of view to really understand what's happening with this young person. Okay, so here is where we're going to tee up the PQB. And this is referring again to the study that we were doing. So you're going to say UC Davis did this study using this great instrument called the PQB. And we did it in a bunch of different places. And they compared me, like doing education like I'm doing right now, to doing the same education plus saying, hey, screen people who come in, preferably at intake, and refer folks who screen positive. And what they found was that doing this screening, we identified significantly more people, 2 times as many people with psychosis symptoms. And then remember how I told you we want to catch people early in the illness? What this study showed is that we caught 3 times as many people early in their course of illness. What we are encouraging our referral sites to do here is to incorporate the PQB into their intake practice. We are not going to go out and screen people at the local grocery store. We're not doing that. We are asking them to screen people who are already presenting with mental health concerns. And in that context, we will find substantially more people when they do this kind of universal indicated screening than if they only screen people who they think have psychosis. That's confirmatory screening. That's not what we're talking about here. We want them to screen all the new cases, and we'll catch more people. Okay. Then we have a little slide that talks about the PQB, and it talks about that 20 or higher threshold, shows them an example, right? And this is when you're saying, I've given this to you in English and Spanish along with a score sheet. Okay. Then the referral process. You say, great, you've screened this person and they have a 20 or above, right? So it says, send a fax to this place. And then you'll pull up the fax form. You'll say, this is our fax form. You'll send it to us with the information, point out that little place to put the score, and then say to them, then we're going to follow up with the client and or caregiver and do a little bit more information. Gather some more information. And that's that phone screen, right? And then you can also say if the score is below 20, but your clinical judgment says, wait, I think this person might be paranoid. And they just said, no. But the vibe I'm getting says this might be psychosis. You can still refer based on clinical judgment. Okay. So you can still, and that's one of the choices up there. If they screen low and you agree, I don't think referral is appropriate, don't send a fax form, don't do anything else, you're good. You can always refer later. Okay. Then here, we're going to talk with them about what to do, because they're always like, this is a whole new world of psychosis, and they're like, what do I do when they screen positive? How do I talk to them? So here's where we get into that part. If they agree to the phone interview, you're going to complete the fax form, tell us what they have, include the ROI. If they don't send the fax form. Try to talk to them again later. So this is really important. They might say no the first time. They might say all sorts of things like, but I just got to you. Why do you want to send me somewhere else? All of these different pieces. Just, it's totally fine for families to have concerns. Talk to them about the concerns. Don't give up. I had one case that I was referred by a school. It took us a year to get the family to agree to come in. We kept going for a year. And there were many environmental factors, cultural and linguistic factors, a lot of different concerns. We were just very patient with the family to get this kiddo in. Okay, so here's the phone interview. This is the script. Based on the results of this screener or our conversation, if they didn't do the screener, I'd like to connect you with X clinic, right? To learn more about some of the experiences that have been bothering you or your child. This clinic provides specialty services. You get that you put your clinic name in to where it says clinic name, right? Okay, I hope so. This clinic provides specialty services for youth and young adults who are experiencing changes in their thoughts, mood, and experiences. A conversation with this clinic might be helpful for both of us so that we can understand what's going on and how to best support you or your child moving forward. Can I have someone from X clinic give you a phone call to ask you some questions to understand more about what you shared today. So this is really teeing it up as I am asking for an expert consult from this clinic, your clinic, right? From this clinic. You're not referring them out. Please keep them open, keep seeing them, because we have an evaluation process. So, and they may choose to stay with you, community provider, and that's fine. We're going to give you feedback. So you're asking for, like, you're the primary care doctor and we're the ortho specialist, right? You're asking for a consult. So you're simply asking to allow us to call them, ask questions, and describe our services. You're not referring them out, and you continue to see them. We will follow up with you, community provider, about the outcome of that conversation and what we think is appropriate. Okay? And then we'll give you this handout of the common questions and concerns that many families have. We've already talked about this. I don't know that my kid needs treatment. These are private matters. Do we have to pay? You know, these are all kind of common questions that a community provider is going to get when they have this conversation. And so we give them a handout to be prepared for that, so that they're armed with typical responses. Then we review that referral process, reminding them, we're here to partner with you. You can always call us to consult. We're happy to answer any questions you have. But if you're going to refer somebody, please use the phone interview form. And then we give them a sense of our time frame. We will follow up within 1 to 2 business days. And this is really important. We are not, at least for my clinic, we are not urgent care services. So this is not a crisis line, no, it is not an intensive outpatient program. Like, we are an outpatient provider. Okay. And then I have a slide that says who we are, what our eligibility criteria are. If there are any things we don't take, I say that here. And then for me, I like to say we serve the continuum of psychosis regardless of diagnosis. That's my little catchphrase. So onset of psychosis, attenuated symptoms. We also take genetic risk and deterioration for those of you who did the SIPS training. Remember, that's one of the SIPS criteria. So for you, you're going to want, again, to work with your EPTTA team to update this to meet your needs. Okay. Then sometimes I've got some extra slides in here, right? I got some other pieces. Like, sometimes people are like, tell me more about this Navigate study that is the basis of the work you're doing. Well, here's the slide. I want to encourage all of you to make your own slide. What does your team look like? Why? Because the biggest question I get is, why should I send them to you? We provide service. And this is so common in the beginning as you start to implement these services, right? And folks don't know quite what you do. In my community, lots of folks know what we do and how it's different from what they do, right? But when you're newer at this, they're going to be like, I don't understand how this is different. So you want to have an image for them. And again, I'm happy to share this, and you can work with the EPTTA team to just like develop it to fit best for you. Okay. Then usually I have this sort of slide teed up after the description of my clinic, and I talk a little bit about the RAISE study, like all of that's in here for you guys. And then I go up again and I say, this is what we're going to do. You're going to interview somebody. You're going to find somebody and give them the PQB. You're going to send us that fax form. We're going to follow up. If it's not appropriate, we will tell you. If it is appropriate, this is what we do, right? We will provide you feedback. Do not close the case. Please. For us, that's honestly one of our biggest challenges. And then thank you. So these are the slides. Okay, so hopefully this helps you to kind of see how we introduce the PQB and provide it to community providers, educate them on it, the rationale for it, and then show them how to use it to then refer people to us. And then we will take that data when it comes to us, right, and use it as part of our intake evaluation. If you are like a subgroup within a larger agency, right, then the first people you might want to test it with is your larger agency and say, hey, we're a new subclinic or specialty program within the Child Life Center. I'm just making stuff up, right? this is what we do. This is how we're different to our other outpatient services, right? You're going to sort of talk about it that way. And so when you go out into the community, you might say to other community providers, say, we're now a specialty program within the child life clinic, so you'll be referring over to us. Thank you guys. Please provide feedback to us. Tell us how it goes. Come back during your meetings, reach out. Let's figure out how best to kind of ramp up this information sharing across the state.